confident with. And it's a really interesting joint because unlike the hip, which there's one diagnosis and one operation, there's actually quite a lot of stuff that's worth knowing about. And I think when you go to medical school, there's a lot of stuff you'll remember and pick up that you think, that all sounds terrible. You heard like rotator cuff tears, or rotator cuff tears are really bad, but then you wander around orthopedic wards and on calls and people talk about cuffs and you say, well, why are they all rushing to surgery? Why do we sort of say they're bad in medical school, but then no one seems to be operating on them? What's the situation? So there's a lot of nuance to it, and a lot of it, as with everything in medicine, becomes about, well, yes, you've got the diagnosis, you've got the anatomy, which we'll talk about a bit today, but then it's about how that actually applies to the patient sitting in front of you, how you apply that, what they're trying to achieve, and what you can actually do with your tools. And I know, guys who've had any teaching for you before listen to me when you talk about this all the time, but I just think the guys who haven't met before, just think it's really important when you're getting this exposure to surgery for the first time. We're bad in healthcare at talking to each other. You've all been told a lot of bullshit about how all orthopedic surgeons are knuckle dragging morons, and it's like, no, there's a fracture, you fix it. But surgical decision making is quite it's not a nuanced thing, it's a very simple thing, which is, can I take my tools, whether it's my operations, be what they are, so call it hip replacement, and can I actually make that patient better with it? And that's quite, a lot of time we come across very arrogant, but in reality what you're doing is very humble, going on to patients saying, can I make you better? And when you say, and the communication is where it all goes wrong, what we're saying we're not interested in the patient is not that we're not interested in the patient, it's just that we can assess it and look at it to say that all the horrible things we do to patients try to make them better, if we could do all those horrible things to them and not make them better, that's a really bad thing to do. And that is essentially what surgical decision making is. So you're saying, can I operate on this patient? Will I operate on this patient? You've got to be thinking about what are you trying to get out on the other end. So I'm going to talk to you a little bit about the shoulder. It's now very upsetting screen. But we'll go a little bit about trauma, and I'll talk to you about some of the things we do. So a little bit of anatomy. Sorry, everyone has to start with anatomy. But the way you think about it is the shoulder's like a lollipop on a stick. Not too dissimilar to a hip, but everything that's complicated about the shoulder comes from the fact that it's not a hip. So in a hip, your ball is loading into a socket. You stand on it, it is physically standing on it, right? Shoulder is floating in space. Although it looks very similar, it is just floating there. It's entirely then based on those muscles that hold it in that space. So part of the bony anatomy, you've got the acromion, that's a normally bit on the top. That's the top shield that stops it coming out the very top end. And then the glenoid is really just a little articulating surface that it kind of is close to. The whole shoulder moves on the basis of the attachments to the scapula. So physiotherapy is a key part of what we do, not because we get disinterested and say send everyone to physio, but because it's true. It's not about bigger, faster, stronger. It's about the fact if you sit there, the brain will try and avoid pain. So I've got a bit of impingement. I'll try and bring my shoulder like this. So try and bring the greater trochanter to the greater tuberosity and lower down. But what is that going to do? Well, it means all the muscles attached to the back of the humeral head are now under strain. So my shoulder will become protracted. So you'll see patients coming in with shoulder pain, and they'll come a bit like this. They'll be hunched over. Quite conscious of that. I stand here like this all the time. But that's why physiotherapy is important. It's muscle balance, it's patterning of movements, and that's why we send them to physio, and it makes a big difference in the shoulder, because actually, if you can, when you're sore and you've got to work on how to avoid the pain-avoiding movements and get back into retraining your body to move normally, that's what actually gives them that pain relief and the longer benefit, rather than sharpening a scalpel and jumping and doing something clever. But that's the key thing to understand about the joint. So you've all heard about the rotator cuff muscles. Everyone remembers them, and they remember painfully trying to remember 4 muscle names and what they do. So you've got supraspinatus, it's the one at the top, comes in attached to the top of the greater tuberosity. Its technical function is initiation of abduction. You've got the infraspinatus, which is external rotator, which combines with teres minor on the back, so those two come together. Teres minor is really minor, that's what I suspect. But essentially external rotation, and it's that kind of movement up here. And the hornblower sign they discussed, I'll talk about examination findings in a minute, but it's literally just trying to hold your arm in this movement, because this arm is not just abducted, it's also externally rotated. Because if I bring myself to here, that's where our external rotation is. So neutral abducted arm will be like this. So when as soon as you put your arm like this, you're in external rotation. That's sort of a weakness movement. That's what hornblower sign is. Other important things is your long-headed biceps. So the pain generators in the shoulder, there's about 4 of them, and they all go into this subacromial space. And the nuances of the examination are trying to identify which of those is causing it, but the patient presents the same regardless. So they don't like going beyond 90 degrees, they've got this painful arc, it's all a bit sore. The history is going to be, well, they might be fine during the day, but they just can't sleep at night, it's agony. And that's just because of hyperemia in the subacromial space. So you blanch your skin, you push on your finger, it goes white. Keep pushing on it for 5 minutes, take it away, your finger goes extra red, right? That's hyperemia. It's a hyperemic response. You get vasodilatation, and that's exactly what happens in the shoulder at night. You've been swinging your arm around all day, you lie down in bed, you stop moving your arm, and all of a sudden that whole space goes on fire. They hate it. But the triggers for it are the subacromial bursa, so a fat pad that sits under the acromion, gets inflamed like any fat pad can, you get bursitis. Your collarbone attaches to the acromion and the acromioclavicular joint. On everyone over the age of about 35 to 40, it looks like it's got arthritis on an X-ray, and MRI scanning will find arthrosis of the AC joint. It's irrelevant unless it's symptomatic, and I'll talk about that finding in a minute. Other structures, your supraspinatus tendon is in that subacromial space, unlike the other cuff muscles which come in lower down. And then your long head of biceps. Remember biceps, two heads. One comes up to the coracoid, the other one, the long head, actually comes up into the shoulder joint in the bicipital groove, which is that groove you sit there, and it comes up into that subacromial space. You've got 4 structures: the AC joint, the bursa, the supraspinatus, and the long head of biceps tendon, all of which can be angry and sore. And all patients will present the same way when they've got an angry sore shoulder if any of those are inflamed. So we'll talk a bit about how to examine for those. But it's just important to understand a little bit of that anatomy for when we talk about some of the things that get inflamed. And the other big muscle we've not talked about is called the deltoid, which doesn't get much of a say in most of what we talk about in shoulder and elbow surgery, except for one very important thing which we'll talk about here. So the cuff, we've talked about it, and essentially we've talked about that humeral head floating in there. Where the deltoid and the humeral rotator cuff come in, the rotator cuff essentially snugs that head against the glenoid. So when you move your arm, it's rotating on that articular surface, your cartilage on cartilage. The deltoid, although it's a big powerful muscle, actually acts as a mechanical arm to pull the shoulder up. So you actually have to have a cuff to protect it against to maintain it against the glenoid. And that is why the rotator cuff matters, because injury to the rotator cuff can cause the shoulder to slip out of place. But the rotator cuff is not a lifelong thing. So really, once you get to about the age of 60, about 40% of people will have rotator cuff tears on an MRI scan. When you get to 70, it goes up about 80%. So the other key thing, on just a slight tangent, is in your experience in orthopaedics, get used to sort of looking at imaging, looking at reports, and and the sort of useful tool for you going into your future lives, whatever they may be, whether you choose to do orthopaedics, whether it's GP, medicine, surgery, IT, whatever. You'll see reports, you go, well, that sounds bad. And we still get referrals for 80-year-olds with a rotator cuff tear. Well, that rotator cuff tear has probably been there for 20 years by that point. So it's a degenerative tear. So you can have acute on chronic tears, or you can have degenerative tears. So an imaging finding doesn't mean anything in isolation. You've got to correlate to the symptoms. So it's a bit like the bulging disc of the MRI finding world. Okay. So things that would just essentially be reported as normal for age, but radiologists just can't quite bring themselves to do it. It's just worth thinking about. So think about what the patient in front of you, think about what that muscle is trying to achieve at that certain time in their life. And that's where we come into discussing the management of it in terms of the patient and the chronicity. I think we've already jumped into there really, but obviously the shoulders, patients come in and say, I've got pain in the front of my shoulder and it kind of radiates out to here and it radiates to my neck and all the rest of it. There's not a particularly sensitive finding. There are specifics which we can discuss, but the patients always get this scribing pain up and down and into their neck because of that communication with the scapula. So because you're moving the scapula around, well, the scapula is attached to all those cuff muscles, but it's also attached to the trapezius, which comes into the back of your neck, up onto the top of your head, all the way down to your lower back. So any of these movements that are pulling them around, you can see why there's a lot of interconnectivity with it. More specific findings would be the AC joint. So the AC joint, if it's symptomatic, will be tender. So I say lots of patients get arthrosis, they get changed to asymptomatic, but it's tender to touch, that's important. And then all the different diagnoses about how pain will present. So the classic pain for impingement is the painful arc. So they'll get to 90 degrees and then they'll be sore. And they may or may not be able to go higher than that, but they'll find that painful. So you describe that in your findings. It goes up from 90 to 160. Rotational movements that are provocative, particular rotator cuff muscles will be the ones we've just discussed. There are other more specific tests we'll do for power of the cuff. So if you're testing the rotator cuff, perhaps we'll can you come up and I'll show you, it's probably the best way to do it. Sorry, I should have planned this a little bit better. So around the examination, you always have a system to do it the same way every time, even if you don't think it's important, because you just catch things. But hands by side, I always tell every patient, so bring your arms up sideways as high as you can, and always show it forward. And so we've described that range of movement from 0 degrees up to about 180. The classic impingement patient would probably bring their arm to here, and then they'll not want to move it. Now, then you do have to encourage them to do so, even though it's a bit sore, and see how far they can actually get to, even without your hands. And then you can describe that painful arc. And what sometimes the helpful test, if you say it was painful, they've sort of gritted their teeth, they now hate you, but say, does it still hurt on the way down? And that can be quite helpful in terms of whether it still hurts on the way down. That's not so much a sign of impingement as the cuff muscles can be aggravated. So they do abduction, but then do forward flexion. So then go same again, all the way up. They'll often get one way will be slightly easier than the other. If they've got true impingement, forward flexion usually is a bit better. Then I say, get your arms up like a robot, tuck your elbows in, and then just drop the arms out to the side. So what we're measuring here is external rotation. And it doesn't really matter what your range is. Textbooks might say, oh, it's 50, it's 60, 70, it's all nonsense. Basically, it's symmetry. So a patient comes to you, you're very flexible, so you've got almost 80, 90 degrees of external rotation. That's sort of a bit more than usual, but that's irrelevant to you. It's not a symptomatic problem. If you do this, something's wrong with one of the two. Okay? So external rotation. Internal rotation, really annoyingly, for your documentation, is not an angle, it's an anatomical landmark. So you say, take your best hand, whichever one it is, and how high can you get your thumb behind your back? So you just turn around, on the way. And so where's your thumb? So probably call it, what, T5? You know, it's roughly like that. Now with the other hand, and then simulate like you've got a painful impingement thing. So you go, okay, so fine, he's now got L2. So a lot of patients don't like it, they'll get to here. So it's about where you are. You describe internal rotation by on the shoulder as where they get their thumb to, okay, rather than an angle. Okay, so then we've got our, so that's our range of movement screening tests. If they did get a block somewhere, then try passive movements. So say Abdul can only get to, you know, says he can only get to here. The next thing I'll do is I'll tell him to relax all his muscles, go nice and floppy. I'm now trying to think structural problem. Do I have a joint problem? In which case, if his muscles aren't working and I move him, well, regardless of what his muscles are doing, every movement should be sore, because the joint is sore if it moves. If it's a muscular problem, but the joint inside is okay, and I move his arm for him, so his muscles don't fire, he shouldn't have as much pain, or should get further. So you just take all the weight, encourage them to do it, and then just bring them up, and then see whether you get different. So that you describe as your any passive improvement. Then it's specific tests. So I then tend to start with here, so arms up like a robot again for me, and push out against my hands. And that's testing infraspinatus, so resisted extension. If that's painful, that's a worrying sign for tendinosis in the tendon, or a partial or full tear. If it's weak as well, that's more worrying for a significant tear. Now again, a 90-year-old is going to have a bit of weakness, but a 30-year-old who has dislocation, who now can't move their arm, or has a pseudoparalysis, and you try and push on it, is weak, that's worrying to me now. They must have an acute rotator cuff tear. So that was in front. Supraspinatus, I do the empty cam test, so forward, thumbs down. And why do you think we do 30 degrees rather than here or here?
Is it to isolate the supraspinatus a bit more?
Yes, but why? Slightly unfair question. If you get a chest x-ray, or even just a standard AP of a shoulder, are you actually looking at the joint straight on? Leading question. No. Good. So the scapula is actually pointed 30 degrees forward in space. So you've got retroversion of the glenohumeral joint. So when you ask for a shoulder X-ray, usually you ask for a glenohumeral joint AP, so that you bring the camera around and actually fire it in this direction. So a chest X-ray is an AP of the person, their skeleton, but not the shoulder joint. So if you're testing and trying to isolate the muscle, well, actually, if they're testing here, they're fully extended. Here, they're really openly protracted. So 30 degrees roughly isolates the muscle, thumbs down towards the floor, puts a bit of pressure on, and again just pushing up in the air. And you're looking for pain and weakness. Subscap is the other one. So the classic medical teaching is sort of hand behind the back, try and push off. You imagine a lot of patients come in and they get to about here. It's not a very effective test. Other variations on it would be the belly press test. So get your hands on your tummy, bring your elbows forward, and then ask the patient to push down to keep the elbows where they are. Because if someone's got a subscap that's torn, doesn't work, it's weak, they're going to pull with their femurs, so they're going to do this. Whereas the subscap is pushing inland, so the subscap's on the front, and it's pulling the shoulder in this position. So if you're trying to push on your tummy and keep your elbows forward, your subscap's doing that movement. If you can't do it, you're going to have to do something like this to pull down. So you're looking, that's the belly press test. The other one is to put the hand, so put my hand on your shoulder, put your hand on mine, sorry for this one. This one. This hand, my hand, sorry.
Okay.
The key to good examination is clear communication. And then I just say push down on, don't let me put my hand away. So he's now doing resisted internal rotation against me in that position. It's called bear hug test. It's also another good one. But in reality, all three of those tests are good to do because the subscap's quite a wide muscle and you have different bellies within it. So the different tests actually provoke different parts of the subscap. But if you do one, just think about, again, most patients are going to come into your clinic and be like this. So I don't find the behind the back one the best one to go for. I tend to use belly pressing, just trying to look at global function. The bear hug's also very good. So then if we think about the acromioclavicular joint, so the medical student keying on the hand, I'm palpating, feel on the clavicle, but then it's the AC joint. Just find it, find that knobbly bit, push on it. Does it hurt? Yes or no? And then you do Scarf's test. So again, patient nice and floppy. You do cross-body adduction. Cross-body adduction will cause pain in the AC joint and put the pressure to it. So if you move the hand and cross-body adduct and your thumb's there and they get pain where your thumb is, that's a positive test for AC joint. And these things are all slightly nuanced, but they're important if we're talking about subacromial impingement, because you'll have all heard about big studies recently about things like subacromial impingement, operations don't work. In reality, it was trying to apply a bit of a blunt instrument operation to a series of different diagnoses. So you want to make sure you've identified your trigger. Am I going to excise the AC joint of every patient I'm going to do decompression on? No. But if they have symptomatic ones, this is the right thing to do. Likewise, long-headed biceps, am I going to do a tenodesis or tenotomize the patient to take it out of the shoulder joint? Well, only if it's symptomatic. And the way we'll test that is another test called Yoga's at the speed. So I get them to hold the hand. So remember, the biceps is not really a flexor, it's a supinator. So first test, just try and put supinator on, and I'll resist, see if that causes any pain. So that's really stretching the biceps and muscle belly. Then bring the hand into a bit of, get the hand up to the ceiling and then push up in the air. Does that cause any pain? And you're looking for pain here because the biceps tendon comes up in here and say it has its own isolated sheath. It's also quite important if you're going to try a steroid injection to reduce inflammation because the biceps sheath is contained and separate to the subacromial space, so it's in it, but only a part of it. So if you inject into the subacromial sheath, GP does an injection, probably in the right place, but isn't into the sheath, may not get a response, and that may not be because it's not the right diagnosis, it just may not be that the injection is targeting that. So long-headed biceps, ACJ, cuff, and then the other diagnosis we were talking about, frozen shoulder. So frozen shoulder by definition is obligate loss of external rotation, so you can't externally rotate. It's classic. If you come in, and it can be from anything, so it could be after surgery, after a minor fall, obviously very common in diabetics, and it's usually a global reduction of movement, but the main one is they won't be able to externally rotate. And the disease pathology, the way I describe it to patients is, imagine your capsule, like a water balloon, very flexible, allows the fluid to move, allows your joint to move. It essentially turns into old boot leather. It's really scarred, really angry, doesn't want to move. And it has a natural history, so it starts in that, I forget the names of them now, but basically it's an inflammatory phase, it's really agony, it's really sore, they hate you and they can't really move. Then the pain starts to get better, but the stiffness comes on and they can't really move it now, but it doesn't hurt so much. And then it will thaw and they'll get their movement back. But that process can take 2 to 3 years. So it's a really long case. So what can we do? Well, physiotherapy and injections don't really help much in reality, because what you're dealing with is just a tight capsule. If you catch them really early on in that inflammatory phase and you can break that inflammatory cycle with the steroid injections, there is some evidence that helps. Basically what we do as an intervention is we just take that scarred up capsule and rip it up to try and give them the space back. So there's 2 ways we do that. One is radiology, so they can inject into the capsule itself, and you imagine that water is really tight, and instead of, you've normally got 5-10 mils of fluid in your shoulder, put 100 mils in. But put some local anesthetic and steroid in there, needle it a bit, and then just try and inflate that balloon to the point where it rips. And then that patient, and then you've got to have really good physiotherapy really early on to get them going, because then they might get that range, and it might be catch them early, that can work. It's called hydrodilatation. If that doesn't work, in particular our diabetic patients, it often doesn't, then we come back to, we call it an EUA and an arthroscopic capsular release. But essentially what we do is we put them to sleep, get anaesthesia to paralyze the patient so the muscles aren't fighting us, and then we'll take, and using short lever arms, we'll sort of pull the arm into the right position to see if we can extract that movement. And it's the same thing. All we're doing is ripping the capsule, tearing it apart, and trying not to break the arm when we do it. So you have to have really nice paralysis. And lots of people will still do the camera at that point afterwards anyway, but if we put the camera in, your camera comes in, sorry, I'm going to switch using you. So the camera, so we have portals in the shoulder, so we go one in the back, goes into the glenohumeral joint for the camera itself. Our sort of working portal will be at the front or the side, depending on what we're doing. And so for encapsulators, you go to the rotator intervals, which is in this place, you've got your coracoid, you've got the muscle here, the rotator intervals here, which is sort of a combination of your middle glenohumeral ligament and the capsule. And we'll put the device there, free all that up, make it window in that scar tissue, and then that usually is enough then to free the movement up. Okay. So that's the sort of frozen shoulder. But frozen shoulder is a really horrible condition, and it's there's not a lot you can do about it. But obviously, you don't want to go in and end up sort of ripping these things open all the time. At least to go to history and it can recur. So that's the main elements of the examination for the shoulder and thinking about pain and where weakness comes from. Does that make sense?
Can I say that? Can you do that at any point in the sort of 2 to 3 years?
Absolutely, absolutely can. It's just that they're all, particularly in the early phase. The vagaries of the NHS, we're not going to catch them very early, and they're already very inflamed. And as with any, inflammatory pathology, things like catastrophic ossification or anything like that, if you go in whilst they're going through this, whatever biological reason they're getting very sore and it's inflamed, you're not going to get that same benefit because they haven't stiffened up yet. Yeah. So EUAing them will probably paralyse them and find them moving quite a lot. Right. But they're still going to wake up inflamed, and you haven't treated the inflammation. I mean, you wash out some of that synovitic fluid or the arthroscopic fluid, but they're probably not going to say, I wake up feeling much happier, and it may well be that the cycle then starts again. Right. So we tend not to try and get them in that early fire phase, basically, but when they're in that stiffening phase and they can't move, that's probably the right time. And also partly it's hard to diagnose when they're still mobile. Yeah. Okay. Any other questions about examination of the shoulder? There are some other nuances about muscle patterning and things. You've got very fit, healthy people who do all their physio and it's not quite working, but they still walk in like this. And one of the key issues, particularly with a lot of people like go to the gym a lot now, or bench press or protracted movements, and that imbalance. So if you think about the cuff muscles, they all sound very important, but they're all piddly, they're tiny little muscles. And when they're outperformed by pec in particular, so your pec by people do a million bench press, they really balance out the back or the shoulder. What they come in is that their pec will fire, and it's really hard for them to get that shoulder back into a nice position because every time they try and do any movement, the first muscle to move is the pec fires, and the little rotator cuff muscles then just go, well, pec's doing it for me, what they're doing. And that's why you have to kind of, the way we trick them out of that is you do things like these kinematic chain exercises, so it's whole body movements. You get a patient to stand on one leg and do their, so if you get, I've had these like bodybuilders, you get them to do this, the first thing to do is this, and you can just put your hand on their pec muscle and it's just firing like crazy. And then you get them to stand on one leg and do the same movement. All of a sudden pec just switches off. Because now their body's going, goodness, core, hip, glute, thigh, it's just firing everything. So it doesn't overreact for smaller movements. So that's some of the things we work on in terms of the movement. Happy with the examination? Any questions about that?
It's a basic question, not examination related really, but what I've never been exposed to shoulder surgery. What are the most common procedures, like the top 3?
Yeah, I mean, I probably shouldn't scoff too much at hip surgeons. We don't have many. So basically, I've put it into sort of underwater surgery and heavy metal surgery. So we have arthroplasty and we have arthroscopy. Arthroscopy is grading in function. So as with any arthroscopic procedure, but particularly the shoulder, we would describe every operation as a diagnostic one, because MRI scans aren't brilliantly accurate. There are things called MRAs, where we inject a gadolinium dye into the shoulder, which used to be used always to the label tears and things like that. Actually, with the new 1.5, 3T scanners, the radiologists are much happier without using the gadolinium. We're actually doing an audit now, we're going to stop using the MRAs. But the point is, we go in there, we're not always sure exactly what we're going to find. So particularly to that point, like I'm going to do a subacromial decompression, but I have in the back of my mind what that pain generator is, try and make some good history and clinical examination, but be prepared for finding what you might find inside. So within that arthroscopic procedures, you might cut the biceps. So for an older patient who doesn't need, it doesn't really matter anymore, cut the biceps, it takes away the biceps pain. For the first couple of weeks, they might have some biceps spasming, which is a bit uncomfortable, then stops. For a younger patient who cares, and because the muscle bunches up, they get like a Popeye sign. The younger patients who care a bit more about that, we can do a tenodesis, so we can basically attach an anchor to it, do it inside the humeral head itself, or actually just make a cut here and stitch it to pec. And that maintains the tension on the length of the muscle. So that's one pain generator. We have the labrum, which is like a suction cup around the glenoid, which is a stabilizer to stop that humeral head popping out. When you dislocate the humeral head, it tends to take that cushion and rip it, and then it also makes the capsule around it a bit more slack, so that people are more prone when they're young to redislocate. They dislocate the first time, particularly those labral tears. When you're a bit older and stiffer like me, actually, if I dislocate my shoulder, my chance of me redislocating again are very low, just because I'm already a bit scarred and stiff. So actually, it's protective against dislocations. But we all might go, so if someone's a young patient rugby player and they've dislocated, they've got a labral tear, we'll go in and we'll put little anchors in just to take that little suction cup and pull it back onto the joint as a buffer. We obviously just look around the joint, we look at rotator cuff tears, and we can repair those arthroscopically. We then actually go separately out of the humeral joint into the subacromial space to look under that bone and do the classic decompression. So we shave down a bit of bone, clear out the bursa, look for any bone spurs which might be causing impingement, which is cutting. So you imagine that, you look at the shoulder, it looks like this, but when you're in that abducted, extended rotator movement, you've brought the greater tuberosity into that space and right up into the acromion. So that's when everything gets a bit tight, a bit squashed. If it's a bit inflamed, that's when they get those symptoms. So we can excise the bursa. If there's a little spur on the bone, we can debride that. You can use the scope and actually debride the acromion joint from there. Open operations, you can take the AC joint out open, which we do here more often. You can do open rotator cuff repairs. And then arthroplasty-wise, it's shoulder replacement. We'll talk about that in a little bit. We can do other clever things. So if you've got ongoing instability, you imagine coming back to the anatomy. So the shoulder looks like that. If you look at it from the top, it's almost like a golf tee, the glenoid, and the head sits in it. So if you go out the front, you can tear the labrum in front. 95% of shoulder dislocations go out the front. They can take the labrum, but they can also take the bone. So basically punching through that golf tee. And then just thinking of that analogy, well, I've now got a ball on a tee which is less big. As you can imagine, it can just slip out. So that's called a bony Bankart lesion. So there's eponymous names. A Bankart lesion is either a labral or a bony one. So if you're thinking instability, just say Bankart, you'll probably be right. You can get a heel sac, so when that golf ball falls off the tee, at the back, so the normal one, the anterior dislocation, will have a divot in the back of the ball. If the glenoid has made attack, it's just dug into it. That's your heel sac lesion. And that's important because if that's really big and really deep, then when that patient's back in joint, and then we're trying to move their arm around, that gap can engage in the glenoid, so it engages it and then levers the head out. So that's why that matters. So then there's things we do where we pull the muscle into the space to stop it engaging. So it's called an off-track lesion. If you've got a bony bit of the glenoid, we can repair that with the latigae. So that's where we actually take the coracoid. So we open you up, we have a delta pectoral approach. We'll cut the coracoid at its base with its short head with the conjoint tendon still on it, and just move on to the front of the glenoid and put 2 screws in to hold it in space. And essentially that makes the glenoid bigger, so your jump distance is a lot higher. So even if you're still unstable, you can't quite get out. And so then joint placement, I want to talk about the nuances of the joint placement in a minute, but those are our main ones. So you either have, most things are either arthroscopic or open, and our real workhorse approach is the delta pectoral approach. So that's where you'll see our patients that will have a cut from there to there, and it's an interval in between. So you go from the deltoid, you've got the pec muscle here, and you find a space down in between the joint caps. So cuff tears. So what are we going to do about cuff tears? Now I've just said to you that lots of people have them and they don't seem to matter. They are an urgent operation, and that urgent sort of should be done in 2 or 3 months in you guys, right? You fall over, dislocate your arm, okay, it may or may not be an instability problem, but you can tear the cuff muscles, and it's important for you guys because if you leave a tear, we know it gets bigger. You can have partial tears or full tears. Partial tears because we describe the rotator cuff by how we look at it intraoptically. So you can look at it from the articular side, so from within the joint, or from the bursal side, i.e. in that subacromial space. And tears can be just in one part of it, not all the way through. We don't really know what to do about partial tears. That's still a big area of debate, but they are painful. It's just you can't really repair them so easily. If you've got a full tear, it will retract. And have any of you looked at atrophied muscle on an MRI before? So if you look at muscle on an MRI, next time you're in front of a future cells an MRI of any of the joints, really look at what the muscle looks like on the T1 scans. It's kind of dark. You see the spots of vessels through it, but it's quite full. When the muscle atrophies, and it does that because it loses its tension, or through neurological cause or trauma, it starts to look like marbled steak. It gets real fatty infiltration. It looks a bit naff. And that's what we get with the cuff tear. It retracts back from its footprint, and the cuff, most of the cuff attaches to the greater tuberosity. It will pull and retract back. If you leave it for too long, the body's really efficient, so muscles, but they get a pseudo paralysis because of this acute tear and how inflamed everything is. So it's kind of diagnostic. And just coming back then to the mechanics of the shoulder, so we talked about the rotator cuff bringing the shoulder into the joint. So if you lose the rotator cuff, you lose that control, you have the unopposed action of the deltoid. And the deltoid is the lever arm where the shoulder is normally pulls up. So you get what we call proximal migration. So you'll see on an x-ray the humeral head starts to drift up over the top of the glenoid. And there is a phenomenon for these chronic ones called acetabularization. So it starts to butt onto the acromion, and it's, because you're still moving it around, it actually starts to form and it looks like a hip joint because they're now actually impacting into the top. There's nothing you can do about that in terms of surgical fixation, fixing those muscles. That damage is done. That bony anatomy is done. This patient now has arthritis. But it does matter because it means that if you're going to operate on a rotator cuff or on a shoulder, particularly when you do a joint replacement for arthritis, you have to have an intact cuff if you're going to give them an anatomic shoulder. So you've all seen hip replacement x-rays or hemiarthroplasty x-rays. They look like a normal hip, right? Head's a bit smaller, but you're just replacing a ball with a ball, cup with a cup. We can, and we do, in the shoulder, but it's less common than a reverse shoulder replacement. The reason being that for most of these patients, the anatomic, even if they're young, if they're borderline age, will sit there until the rotator cuff starts to fail, and then when it starts to fail, you've now got metalwork coming out unopposed into the shoulder joint. So what we do is we do a reverse geometry shoulder replacement, and that's where, and what the reverse is, essentially turn the ball into a cup, and the glenoid cup into a ball. But what that actually does is it medializes the center of rotation. So if you imagine this looked like a shoulder before, like this, your center of rotation is here, in the middle of the ball. So when you're moving it, that's what means when the deltoid is firing, it's got that upwards function. When you move the center of rotation to here, so now this is the ball, it actually changes the moment arm of the deltoid. So once you've got this, the deltoid becomes a more oblique force, and so it itself is holding the shoulder now in joint. And your deltoid, for whatever reason, I don't know the answer, seems to live forever. So even when you're a 95-year-old crumbly patient, you've still got a functioning deltoid. Obviously, for us, if we're doing this for trauma patients, you have to make sure they have got auxiliary nerve port disease or any which will turn off their deltoid, because then they can't have a reverse shoulder replacement. It's not an option because it will fail. You do need to have a deltoid, but those patients are rare. But people tend not to have a non-functioning deltoid through age. So it's a really good function. So what we actually find out is we're doing reverse shoulder replacements much more commonly and more preemptively, and it is a treatment for rotator cuff degenerative tears with pain, even though you haven't got really bad arthritis yet, because actually it's the only way to rebalance the power in the shoulder. We can do it for trauma. Proximal humerus fractures, the other big hot topic. You might even have heard of studies like PROFA in your medical school doing. There's this big study that came out quite a long time ago now, which suggested that essentially at around 2 years, patients did, the way it's often interpreted is that 2 years, patients do just as well with surgery as without surgery. So they might be better more quickly with surgery, but at 2 years, they all do the same. Problem scores are the same. So, bad shoulder surgeons, back in the box, stop operating on people, non-operative measures, why would you do the risks of surgery? The reality is that it wasn't a great study. It didn't include what we call 3 and 4 part fractures. So we describe shoulder fractures as parts. You've got the subcapital bit, the articulated surface, what you expect, but you have those 2 tuberosities. And you probably now appreciate a little bit more why that matters, because the tuberosities, it's not about the bony fragments or the orientation or the drama of that, it's because they are the cuff. They're how the cuff attaches to the shoulder, but they attach to the tuberosities. So what a multi-part fracture is, or fractures involving tuberosity are essentially a type of rotator cuff injury. And that's why it's important. So if you guys break your shoulder and your tuberosities are broken, that's really bad news. I need to get those tuberosities back where they're supposed to be, not because I particularly care about these non-articulating bits of bone, but because I need them to be back there so your cuff works. That's really important. Then if your humeral head dies because its blood supply has been damaged or whatever, well, I've got options. I can do that anatomic shoulder replacement. I can do the hemiarthroplasty. But if your cuff is left to fail and you get arthritis in your shoulder in your 30s or 40s, a reverse shoulder replacement, it's going to work okay, but you're not going to like it that much, and your revisions with the reverse shoulder replacement is very different. So it's a real problem. So think of the shoulder fracture as not only a broken bone, but as a almost like a cuff injury is the way to think about it in terms of what you're trying to achieve. So if you're looking at, you're looking at shoulder fractures we don't treat, and again, why are you getting 85-year-olds falling over and got really horrible fracture? Why are we just leaving them in a sling? Well, the bones will gum up. They already have low function. They can work within a range, and they'll compensate. They'll probably do okay because their cuff's already it's not really working. They've already compensated for that. You guys won't be able to do that, and you'll get arthritis really quickly. So they're slightly different. So we're going to flay you open. We're going to put metal plates in, and we're going to try and bring them together and try and get it to heal in the right place. But even in older patients who we don't treat, just be wary of things like this. So the isolated GT fracture, it's only a one-part fracture, it's not even in the joint, it's still the cuff. This patient, old, knackered patient, humeral head's fallen off, they're managing in their in their sling, and when you see these patients, you don't want them in a sling like this, or just top tips, collar and cuff. It's not just because we're trying to save the NHS money on slings, it's an actual it's functionally beneficial. So if you put your hand up like this, and let the weight of your arm drop down, if you imagine the deltoid and the cuff muscles as like an octopus, if you hold your shoulder like this, it opens up, and therefore the muscles are all the bones are going to rattle around, it's going to cause pain, it's going to be unstable. And then if you bring your hand up and the weight drop down like this, that gets those muscles are on stretch, so they're tight, and it stops the muscle of the bone being able to move around so much, so you get stability, which is the thing that actually helps with pain relief, and it helps with heat. So collar and cuff looks rubbish, but for any upper limb fracture, much better. But yeah, you can't leave this one. You might say this patient is going to have an operation, that humeral head's never going to survive. Does anyone know what structure is going to be very near to this that might make us sad? Who's wrong? Axillary nerve, yes, the axillary nerve comes right down through there. I'm not going to sort of quiz you on the intervals of the shoulder, but essentially, yeah, the axillary nerve is in that space, and particularly if you needed that, that's an operation you want to do in that first 2 weeks, because you're going to have to get that humeral head out, and you don't want that to be scarred down into the brachial plexus, which the axillary nerve, you don't cause damage getting it out. It's quite tricky. So yeah, these are the sort of things where you go, not all of these fractures are created equal. And this other one in the end is, again, quite a normal looking fracture, but just something to be mindful. It's called a varus impacted fracture. And the blood supply to the humeral head is on the medial calcar. Essentially, the little curve of bone on the medial side of the head. So, although that looks like a fairly innocuous fracture against when you see a lot of these things, it doesn't look that impressive. It's one to be mindful of, because actually that calcar's gone, you probably lose the blood supply and it's probably going to die. So you either need to reduce it to take that pressure on and hope it heals, or already thinking about your next salvage operation. That's pretty much it. Does that give you a little bit more insight into some of the shoulder stuff? It's it's cool. There's lots of stuff happening. It's really nice. I hope you're probably just starting to appreciate now that orthopedics is. I've always liked it as a specialty just because it's really multidisciplinary. You can do either savant in surgery, but if you don't have good physiotherapy, if you don't have good medical colleagues, if you don't have that admin support, you just can't function. So it's all about teamwork all the time, which is really I've always really liked. The shoulder's a good one because this is physiotherapy is a key part of it. You can talk to patients about it and get them, try and get them going, and the anatomy is really interesting. And the surgery is cool, and it's getting better all the time. It's an area where a lot of the old techniques we've been shown not to work, or we were using them poorly. But again, another good thing about orthopedics is that we're all into big data, really driving that as one of the few specialties that's really looking at everything we do and go, are we doing the right thing? Not to save money, but just sitting there like, hands up, are we doing much stuff that's a bit shit? And really then, we're lucky, we've got X-rays, got really easy ways to measure things. But using prompt data, using X-rays, trying to drive innovation in our technology so that we're doing better all the time. I think it's quite exciting. And the shoulders, we're the poor cousins to hip surgeons, they're putting in 600 a year, and we might put in 30 or 40. So we are getting better all the time, technology's getting better, and the outcomes are getting better. So it's cool. And who knows what we'll be doing in 10 years' time. Hopefully not big studies saying, why did they ever do reverse shoulder? Why did they ever give them a medical license, by the way? But yeah, so that's it. So you're very welcome. We operate on Mondays and Tuesdays every week. Chris is on Monday. He does elbows, and he does everything, but he does all the horrible elbows. So we're not talking about that today, but the rheumatoids. You still probably the elbows are one joint that even the biologics don't really seem to have fixed. So you still get rheumatoid elbows. You do elbow replacement. Elbow replacement is a salvage procedure. It's not a functioning joint like a hip or a shoulder. and dealing with the complexity of that infection of the back of bone. Tuesdays usually Profilum or Anti-Titchener, again more shoulder based generally, so we do more scopes, we do joint replacement. It's quite hard to cram around the shoulder, but you're always very welcome, so please feel free to come and join. The other good thing about upper limb surgery is they all have working legs, so they all send to discharge medically. So, all right. Any questions, any burning issues, even non-upper limb based that you've all been here for a while now, questions you want to ask?
What's your favourite shoulder operation?
What's my favourite shoulder? Reverse shoulder operation. I love it. So I'm in that dangerous period of life as a fellow where I'll operate on everything. I'm not competent enough yet, but I'm just going to keep on. That's the only way to get there. Yeah, that's great. I just like the tendon. I just like the anatomy's fun, and you put the implants in, and just feels like just completely changing the anatomy of the shoulder.
What sort of, so I hadn't really realised about sort of like rotator cuff tears and if you don't repair it, sort of the chronic pain.
Yeah.
What's the sort of, someone that was very far down that line of things, if it's not going well, what sort of are the more drastic things that can be done?
Our sort of first conservative treatments is we love a steroid injection into the subacromial space, just breaks the cycle of inflammation, physiotherapy, pattern movement, blah blah blah. If they've got an irreparable cuff tear and they've got pain, particularly for an older patient, actually the treatment is reverse shoulder replacement. If you've got intractable pain from chronic cuff tear and you're old enough, actually reverse shoulder replacement is very reliable. There are sort of fancier techniques where we can do some supercapsular reconstruction, where we can put in allografts or try and move others. You can actually take the long head of bicycle tendon, shift it over the top of the glenoid to act as a buffer to stop the head coming up. You're basically just trying to stop the head moving and just constrain it a little bit more. Just try and take away that pain generator. There are people do things like pieces transfers and some funny stuff like that. But it's if you've got a chronic and then pain management. So we talk about the generic steroid injection. The other thing we do is suprascapular nerve block. So the suprascapular nerve supplies the infraspinatus and supraspinatus. You can actually block it just through the top of the nerve here. If that works and takes away their pain, you can actually do a radiofrequency ablation of it to try and give them more permanent relief. In theory, it could last for the rest of your life by a few years. It tends to be enough nerve plasticity that some of it recovers. But that will cause some weakness to those muscles, but it doesn't cause bigger problems than that. So again, you've got chronic degenerative tear, a lot of joint-based pain, that can be helpful. And then when we're really stuck, this is what comes back to the humility/arrogance of surgeons. We just sometimes have to say we can't help you. It sounds like a really innocuous thing to say, but my experience, I've done ITU and medicine and the rest of it over the years, and even when I got redeployed with COVID, because my ITU experience into the actual ITU, you kind of lose sight of how often, every clinic, every day, I have to look someone in the eye and say, I'm sorry, I can't help you. Quite a tough thing to do. It doesn't make you feel good about yourself. But understanding what you can and can't do is hard. And of course, if you're a medical specialty, there's always another million drugs you could try, there's more investigations, whereas surgery, at least when you've got your little sandbox of toys, once you run out of those or you don't think they're going to help, it's quite you have to learn to have those difficult conversations. So who helps us? Well, pain clinics. And they're great, because they've got capsaicins, clever drugs. They have those, the good ones have those combined services, psychology, physiotherapy. There are reasons someone can have their leg blown off before to save their lives. So in the same way, the brain can be down-regulated, it can be up-regulated. So I think it's really interesting. I don't know enough about it. But who knows, in say 5-10 years, maybe that question will have a very different answer. Like, it's the artificial rotator cuff nasty. But at the end, surgery has got space for that. It's got lots of research. I commend it to you if any of you are undecided. Again, this idea that surgeons can't part time. Oxford, I've been the chief resident here for registrar here for the last year, and we're probably the biggest one in the UK for part-time working. Learning for students, people having maternity leave, all that kind of stuff. It's a lot better than I think it's historically been told about. It's still a lot of work to do, no doubt about it. But I think it's a lot better. You don't have to sacrifice all to be a surgeon. So do think about it. Gosh, really popular.
Thank you very much.
Thank you very much.
And pizza.
Thank you.